Okay, so welcome everyone who's joining us remotely. This is clinical Kodachromes session, and I don't think in this particular session, but we always do general acknowledgement that there are some that were contributed for educational purposes, including by the JAD and by Cutis. So, and we always encourage people to do those online images because they're really good. So, Brian, you want to start us out?
So it looks like we're looking at a leg here. And
Maybe axilla.
Okay, an axilla. And just kind of like a reticulate hyperpigmentation, almost a little poikilodermatous. Doesn't look like there's a ton of surface change to it.
I think these may be the lesional.
Little like flesh-colored papules.
I'd say to my eye more, there's a background with some erythema, maybe a little hyperpigmentation, but I would say rather than this reticulated being the lesion, I think that's more background erythema, and these are raised pale papules.
Okay. Think about things then, some of the connective tissue disorders. Doesn't quite look like an anetoderma.
Yeah, anetodermas they certainly pouch outward, often more on the trunk. Anyone else want to jump in with some ideas? So Fox Fordyce, it's certainly an area for apocrine miliaria, and they can be more at the periphery of the axilla rather than in the vaults. So Fox Fordyce apocrine miliaria would be high on my list. PXE I heard mentioned, and I think PXE very much belongs on the list as well. I would look on the sides of the neck. This looks maybe a little less yellowy than PXE can sometimes look, but there's certainly a spectrum. So those two would probably be my highest two in the differential. Biopsy can certainly help with that. What are you likely to see in PXE? Squiggles, so calcified, squiggly, elastic fibers, and derm path fellows. Tom, what are you most likely to see in Fox Fordyce?
In Fox Fordyce?
Yeah.
Increase in sebaceous glands.
So Fordyce on the lips certainly are sebaceous glands. Ashley, what do you think for Fox Fordyce? So sometimes you see dilatation and spongiosis in the apocrine duct, but more often you see parafollicular xanthoma cells localized. So, which is sort of like a downstream what happens after the duct ruptures. So, the name is apocrine miliaria, that's the pathophysiology, so you wouldn't necessarily expect that pathology, but that's a very characteristic, would be fair for boards, is you've got a parafollicular xanthoma, match that with the right clinical, which would be Fox Fordyce. So a xanthoma sitting next to the follicle, probably from just the rupture and the degenerated cells. Okay, Christina. Yeah, so most likely infantile hemangioma. So infantile vascular lesions go into vascular malformations and proliferative lesions. Which side would this fall? Definitely proliferative. So the sort of thing beta blockers do work for. And then more like just regular infantile hemangioma, or more like rich niche?
You mean, this is more like a regular, but you can't really tell without the history for sure.
So you definitely need history and GLUT1 staining, which would be positive or negative in this one. Yeah, GLUT1 positive, just like placenta, in a regular infantile hemangioma. And there's still a school of thought that it may be embolic placental tissue, and certainly stains like it. And rich and niche would be negative. And they often have, there is a little bit of white avascular area here that's often more pronounced in rich and niche. I agree, this is more likely appearance of just an infantile hemangioma. Okay, Sean.
Okay.
Unless we're going by pseudonyms today.
So looks like we have these kind of plum-colored, darker, dull red violaceous.
So I definitely see shades of plum, dull red, and violaceous. What other color?
Bluish there. A little bit of yellow.
Yeah. I was going maybe for some brownish in there. And if there's some brown, what pigments give you brown?
So hemosiderin, melanin, lipofuscin.
Hemosiderin, melanin, lipofuscin, absolutely. Those are your big three. And in terms of the shades of red that you discussed?
So, red, brown, violaceous. So plum color at lymphoma, leukemia cutis.
So plum colored we associate with lymphoma, leukemia cutis, Merkel, other tumors. Okay.
Red-brown makes me think of things like sarcoidosis, other granulomatous processes.
So red-brown, sometimes sarcoidosis. The brown there is often a post-inflammatory change, melanin. There's also the apple jelly component of those, which is carotenoids dissolved in the aqueous phase of cytoplasm. And then when you squeeze the blood out with diascopy, all that's left is a mass of cytoplasm. And so you see the yellowy apple jelly color of carotenoids in water, just like serum would be that color. Right? Other things...
So like vascular processes.
Vascular processes, and if it were vascular, then the brown would probably be hemosiderin. So we did pretty good with color. Now we've got distribution and morphology. So distribution, that's probably an axilla.
So this is the back of the chest.
And in relation to skin lines,
They seem to be lining up.
so sort of parallel to skin lines. So elongated, parallel to skin lines. And in terms of morphology, round, oval, elongated.
PR, based on that distribution.
And the ends, are the ends the same diameter as the center, or are they somewhat dumbbell in appearance with broader ends? Anything that you know of that fits into those categories we discussed, that goes along skin lines and has a distinctive dumbbell appearance where it spreads at the ends? Do inflammatory things tend to spread at the end like that, or is that more tumor things that spread at the end?
It's more tumor-like.
Yeah, tumorish, like a keloid will do that commonly. Infiltrative types of things do that. So if we're thinking tumorish with that dumbbell appearance, vascular tumor with hemosiderin deposition, KS, and this is a classic. We're back to seeing more old man type KS on the lower legs, back at the height of the AIDS epidemic, this is what walked in the door every day was epidemic KS, which is more eruptive. A PR-like distribution was often described because it, like skin tension lines, tends to be elongated along them, but has a dumbbell appearance very similar to a keloid. And then you've got the hints of the red for heme, but a little violaceous, which is stasis deoxygenated heme not flowing, and then the hemosiderin, all as clues. Well done. And this is another HIV patient with eruptive KS, and again along skin tension lines, kind of PR-ish in distribution, but red to violaceous with some brownish hues. Okay, Rob.
So,
Yeah.
so we have red color, so brownish on the last one, and the edges.
And is this brown, or are you picking up some other colors here? So I agree, those colors are in there, just like the last one. How about out here?
A little yellowish.
Yeah, yellow-greenish. So what are kind of yellow-green pigments in skin?
Like, I guess like lipids, more yellowish.
So lipids can be yellowish, but do they tend to be greenish?
Usually.
So yellow-green. What goes from black and blue to green and yellow as it resolves? Like a bruise. So that's heme components breaking down to bilirubin and biliverdin, right? The rubin is yellow and the verdin is greenish. So again, suggests it's a vascular lesion with chronic erythrocyte extravasation, giving rise to hemoglobin breakdown.
So it has like irregular borders, maybe like angiosperm.
So you could think of angiosarcoma, some sort of chronic vascular lesion. Could the whole thing be a late stage of a vasculitic lesion or a bruise, a traumatic lesion? I suppose those are in the differential too. But I would think some sort of very chronic vascular proliferation associated with red cell extravasation. And this particular one, it's not very THH-ish, but in terms of having a hemosiderin ring, but I think that's where it fell histologically, hobnail hemangioma. Okay, Adam.
Okay. It's like an extremity, maybe over a knee. Some reticulate, apparently non-blanching.
So reticulate, and we can't perform diascopy on the static image, but I agree. I mean, it looks purpuric, if anything, and it doesn't particularly look like it would blanch.
A little bit of skin breakdown in the centralmost area where it's a little bit darker, but
yeah, there is a little bit of late epithelial change, a little bit of scale, very, very late, suggesting a little maybe secondary parakeratosis, which equates with scale. But it certainly doesn't appear to be part of the primary process here. Late post-inflammatory change.
So, I mean, where we are and kind of the look, I'm thinking about kind of two different types of things. One is a vasculitic process. So I'm thinking about that. I'm thinking a little bit larger vessel, like medium, but rather larger than small, I guess, medium vessels. So,
correct. So if this were in the vasculitic group, which for a purpuric lesion is important to consider, to give a livido type of pattern or a reticulated pattern of purpura, retiform purpura, or stellate infarctive areas, it would be on the arteriolar, larger vessel side. And classically with a racemose livido, which means a broken ring pattern of livido, which one would fall in there? polyarteritis nodosa would be kind of the classic, but you'd consider all of those, which would include septic vasculitis, rheumatoid vasculitis, and the ANCA-associated vasculitides. And then what on the other side? Non-vasculitic.
Well, so I was thinking about things that can produce kind of, I guess, vasculitic or pseudovasculitic things within them. So like EED, which would be on an extremity.
Erythema elevatum diutinum tends to be more plaque-like and often goes a little bit orangey over time because of the lipid deposition. But I think that's fair to include. What else? So we did inflammatory, anything neoplastic.
I mean,
Angiosarc. For neoplastic, it would almost have to be something occluding vessel. So the only thing I could think of that would be likely in the neoplastic realm would be something like an angioendotheliomatosis or an intravascular lymphoma to do an appearance like this. Something that would be neoplastic inside a vessel, because vascular occlusion is kind of the common, for livido patterns, the common pathway. How about infectious? Anything mimicking? Syphilis can look like anything, right? So that belongs on virtually, in an adult other than vesicular or bullous, which you see in congenital syphilis, but not other forms. In an adult, any morphology other than vesicular or bullous, syphilis belongs. So some viral could do it, and then the other things you might consider a deep, more invasive tinea with Miyakis and someone immunosuppressed, perhaps. So someone maybe who had no platelets and was immunosuppressed, a leukemic patient with tinea could present with a similar pattern. So that's a pretty good differential based on the morphology. This particular one I think was PAN. But yeah, polyarteritis nodosa. Okay, David. But it's more important the exercise of thinking through color morphology, distribution, and differential, because in real life you'll have history and you'll have biopsy findings to put together.
Multiple brown, cercinate, red violations from.
Good use of cercinate rather than annular. You're absolutely correct. So an annular lesion is ring like a donut with a clear center, and these are cercinate, which means round. Well done. Go ahead.
Maybe like slightly necrotic in the middle.
Slightly necrotic in the middle.
Or just more purpura.
Or more purpura. Is there any color other than purple in the middle?
Maybe a little more brown.
Maybe a little more brown in the middle, which again makes you think of melanin, hemosiderin, or lipofuscin. In this case, probably less likely lipofuscin, more likely either hemosiderin or melanin. If it were hemosiderin, then we'd be talking about vascular lesions. Melanin more with inflammatory lesions, and it looks like as it's fading with hyperpigmentation, right? So what things might you put into your differential? And again, there's probably a little secondary post-inflammatory parakeratosis there manifesting a scale, but not part of the primary process.
Like a leukemia cutis infiltration.
So absolutely, leukemia cutis could look very similar to this. The only thing for leukemia cutis is it looks like they're in various stages of evolution to include resolution, which might be less likely leukemia cutis, but you can get fooled, so that definitely belongs on the list. What else?
Sweets.
Sweets, and if it's a sweet, this would be a dusky, atypical sweet, a leukemia-associated sweets rather than the bright red, hot, juicy, no post-inflammatory change sweets that's URI associated in young women. This would be more of the I'm afraid you have hematopoietic disease type of sweets. What else? What else is red to violaceous and heals with hyperpigmentation? And then we'll come back again and again at the same spot and leave more and more hyperpigmentation. Fixed drug. And fixed drug starts usually with a single lesion that leaves a little bit of hyperpigmentation. And then as it keeps coming back, you start getting more lesions. So generalized fixed drug is many times recurrent fixed drug, where you start to get more and more and more lesions over the trunk in people who are repeatedly exposed to the tetracycline or the sulfa or the Tylenol or whatever is causing it. And this does not seem to want to advance.
Are you on the PowerPoint or you
I'm sorry?
Are you
I'm trying to use the down key, the down arrow. Like here, you mean?
I think you might be off on the
Oh, you think I'm on the Bradford? I get. Aren't you clever? Very good. Okay, Jessica.
So you have some white plaques, so yellow plaques in the tongue.
Okay, so we see white and we see yellow. So look at each morphology. What do you think the yellow is?
It looks sort of elongated and angular borders.
Yep.
More popular in the back of the tongue.
Okay. Yes, you try to wipe it off, and here it would be pretty adherent, but if you're really forceful, you could get to blood red ulceration underneath. And so that's probably all fibrin. You know, fibrin is white to often yellowish adherent. So this is probably just ulceration on a mucosal surface with a fibrinous eschar that's macerated. And then the white, you talked about papular. These are just the circumvallate papillae. But any other pattern to the white? A reticulated lacy white on a mucosal surface associated with ulceration. Lichen planus would probably be the top of my list. And then I'd look at the buccal mucosa. It looks like we got a little bit there, maybe even a little bit on the lips as well. So LP would certainly be top of my list for this. If that is a buttock cleft.
Look at that. Kind of a nondescript skin-colored nodule.
Okay.
Not a lot of surface change.
Is it
Maybe some
shiny and taut, or do you have accentuation of skin lines and hyperkeratosis with some reflection of light? So the second thing, suggesting you have what kind of secondary process happening here?
You do a little like hyperkeratosis.
Yeah, or lichenification. Like it's been chronically rubbed or chafed, more likely in this location, giving you some lichenification of the surface. You know, probably means it's just been there a long time, kind of annoying and chafing the patient. And then the lesion itself, do you think it's more likely something that was rock hard, more likely something that was softer?
It's somewhat soft.
Probably softer, given that rock hard things tend to expand and stretch the epidermis, cause atrophy, other than those few like granular cell tumors and DFs that cause hyperkeratosis and acanthosis. This more likely to have that kind of lichenification probably would have been a softer lesion. So thoughts?
Well, it could be anything under there.
Any colors that you're picking out here other than the heme, which would be the pink red? Yeah, maybe skin color. I'd say maybe there's a little yellowy in there. I don't know.
So it could be like a, like coma that's deeper, like you have a herniated something.
Is there anything that's a herniated lipoma-like thing
it's
named by Hoffman and Zarell that would be in this location?
Yeah, it's with a thing. It's like lipoma in the name. It's like lipomatoid.
Yeah, you mean like nevus lipomatosis superficialis? Is that what you're going for? Yeah, that's probably where I'd go at the top of my list, although, other things certainly could do it, but it would be a very characteristic location and appearance for nevus lipomatosis superficialis of Hoffman and Zarell.
Of Hoffman and
Zarell, which in German I guess would be like Zarelle, but we all say Zarell, because we mispronounce every historical overseas person's name. Okay. So if you want to sound like an American when you say it, you say Hoffman and Zarell. It's probably Zarelle. Okay. Katie.
Okay. So on the medial plantar aspect of the foot, just the first toe, it's like a really large, tense. I'm gonna say it looks bullous because the way the light is reflecting.
Yeah, I agree. It looks bullous. And would this be a unilocular or a multilocular bulla?
So it looks unilocular.
Can you make out little things that look like tapioca within it?
I'm gonna go with yes.
So to me that suggests multilocular. When you see these little, I don't know what color you want to give them, but you've got the macerated surface, and then you've got these more pinky or serum colored areas that are like little dots of tapioca in it that to me suggest something multilocular. So, and that might mean like reticular, spongiotic or reticular degeneration to give that appearance rather than a subepidermal split.
So, I mean, it's pretty big for a friction blister.
I agree, and friction blister is more likely to be unilocular.
Those are
usually unilocular. So multilocular, large blister, sole of a foot.
Well, think about contact with them.
So contact, and to get this kind of rip-roaring vesicular contact, what allergen most likely?
So it could be the MBT.
MBT, classic. So thiram is more like chronic dorsal of the foot, whereas MBT is you got a little bit of the glue that's spilled out, or it's actually in the insole, and you're having this rip-roaring dishydrosiform vesicular reaction. And then speaking of dishydrosiform, what else could be in your differential?
So like tonsillitis on the foot?
Yeah, exactly. So dishydrosiform dermatitis, dyshydrotic eczema belongs there. And what else? Sole of a foot, bullous, multilocular.
You think about bullous tinea.
Absolutely. I mean, that kind of hits. So an MBT type of allergy, dishydrosiform, or bullous tinea. And bullous tinea would probably be my top for this. So how are you going to prove that?
Get your slide. Do it.
So you're going to scrape it, and is this one, so you're alluding to the fact that I like to scrape with two slides. So I scrape with the end of a slide onto another glass slide because it's one, cheaper, you never cut the patient, and you get way more scale doing it that way. And I do that for anything where the fungus is going to be found in the loose scale. in bullous tinea, where's the fungus likely to be found?
So you could pop the blistering fluid.
So is it in the fluid? Think histologically. You're going to see a usually reticular degeneration or spongiosis, a layered corneum, basket weave on top of compact, and where are all the hyphae?
I thought that they'd be on the surface of the bulla. Like if you took the...
Yeah, down in that compact layer, so at the bottom of the corneum is where you see them. So the best thing to do for this, it's a little different from the way you approach any other KOH. You unroof a portion of the bulla, you flip it over, and you scrape the wet undersurface of the bulla roof. That's where you're going to get your yield. Because it's not the top of that thick corneum. It's that compact red layer at the bottom of the corneum where all the tinea like to live. So from the top, you're just going to get keratin. So different from any other tinea, you're unroofing bulla, flipping it over, and scraping that wet undersurface to get your highest yield.
So would you use a blade in this to rupture?
Correct. So for me, this is going to be a 15 or 11 blade. Unlike any other tinea where I don't go for a blade. Yeah.
I've never seen plantar pemphigus. What is that?
Plantar pemphigus. Yeah. But I'm not sure I've seen it clinically
I haven't seen a photo.
either. So what would it look like? I would expect it to be more of a unilocular bulla because of the split, but I'm not sure I've ever seen that.
We had a BP patient, inpatient services with bullous pemphigoid who had a bunch of palmar lesions, and they were all big hemorrhagic bulla.
So BP I have seen acral, and in patients who are really bad, and like DH patients who go on a trip and forget their dapsone and have their bullous flare. That I've seen, and that is a tense, taut, unilocular bulla. And I've seen it with linear IgA on acral surfaces. Okay.
So here we have some pretty dystrophic toes with almost complete loss of the nail on 2 through 4.
Yeah.
Relative sparing of the great toe though. Looks like you have focal areas where you have small abscesses or areas of pus coming out as well, a lot of crusting.
Yeah, so either just serum coming through in fibrinous exudate or purulence, certainly something you would want to culture for secondary infection.
Mm-hmm. Oddly, like the rest of the foot looks almost completely spared. There's nothing in the web spaces.
Yeah, so
it's the dorsum.
Agree. So web space is clear. It certainly seems to be acral sites.
For this one,
or the most distal portions.
My first thought was something like along like a pustular psoriasis or I think acrodermatitis or halopo type.
So acrodermatitis continua of halopo. If it were that, you'd expect some yellowy to white pustules to be on a very blood red base. Possibly during a partially treated phase, it could look like this. So absolutely it belongs in the differential.
Infectious etiologies as well, for sure. I think it's a little odd that you have almost complete removal of the nail plates though on those four, sparing in the other one.
So for something like a blistering dactylitis, which would be streptococcal, would be unusual to get this kind of chronicity and change in anonychia. So remember, anonychia, there ain't no nychia, right? So no nail. Okay.
You could also think about more simpler things like a trauma, like a neuropathy-driven type of a process. But again, it seems pretty focal, and I'd expect the great toe probably.
So a trauma. So how about the kind of trauma, repetitive minor trauma that you and I experience every day, but this patient is experiencing it differently? What might make this patient experience it differently? Maybe because their skin isn't quite as resilient as yours or mine.
True.
Because they've inherited
Remember the epidermolysis bullosa.
Bullosa variants, exactly. So EB would probably be pretty high on my list for this one. And this was actually EBA, so not inherited, but immunobullous EB.
So, is there one thing to deep red violaceous papules involving the shaft, the scrotum, and the pubic area as well as the intercostal fold?
Okay, so pink to violaceous, thigh, inguinal fold, shaft, suprapubic, scrotum, all involved.
I'm kind of worried about extramemory pageants a little bit in this, please.
So neoplastic and extramammary pageants absolutely would have to be on your list. I mean, this is going to be a biopsy diagnosis in part, or in large part.
I mean, that's where I couldn't. Maybe infections is hard because a lot of the infections that we think of in the groin don't involve the shaft and the scrotum.
So your point being that things
like different areas.
Correct. So tinea and candida, it's unusual to get involvement of both shaft and scrotum in conditions such as that. So you're focusing on neoplastic. It's not particularly erosive like a glucogonoma might be, and this was extramammary pageants. And this particular one was given, this is not my patient. Most of the images you've seen are mine. This one's not mine. And usually I put in if it's courtesy of Cutis. I don't have it on here, but I think this may be a Cutis photo quiz. Either that or something a friend gave me. Okay.
Okay, so on the trunk, kind of side of the trunk here, we have these yellow, small, yellow-pink papules mixed with some more inflammatory, pink-red kind of papules.
In the distribution?
Say, kind of usually standard.
You think random or associated with some pre-existing skin structure?
Parafollicular.
So maybe follicular. And I would say I see transitional forms that seem to go from follicle to a little follicular hyperkeratosis to the lesions.
Okay. So, I mean, with that kind of distribution, I mean, the first thing I thought about at first was folliculitis.
And to be a folliculitis this widespread,
it would be more like a pittosporum, or like a steroid-induced.
So Pittosporum acne, including a steroid-induced acne. One of the things you can do very easily to evaluate that is take your Woods lamp. If it's Pittosporum, the center will glow green, and if it's acne, the center will be hot neon pink because of the porphyrins of P. acnes versus the Pittosporum fluorescence. So that's an easy evaluation. And if it's just keratin, it reflects the blue light as bluish white without either particularly green or neon pink. So you'd look for those possibilities. Things like an impetigo Bockhart, superficial spreading staph impetigo, tends to be very pruritic. What if it's just keratotic?
Just keratotic, I mean, keratosis pilaris would be a weird distribution here.
Yeah, odd distribution for KP, but for eruptive vellus hair cysts might be just right on. So that would be kind of my differential, and these were eruptive vellus hair cysts.
What do you like to do for me?
Oh. Yeah. are kind of rough to treat. Easy to diagnose, reassure the patient, hope it doesn't bother them and they're willing to live with them. You can try retinoids. Usually right around where you get efficacy, you get irritant dermatitis. A systemic retinoid for them would be tough. I don't tend to do very well in my management of them. Rich, are you much better?
Pediatric dermatologist, like different or nothing?
Different or nothing. Yeah, I mean, different would probably be your best tolerated of the retinoids. I'll do it in pulse dosing, like just weekends. Hope for the best.
Yeah, gotcha, please.
Okay, Rob.
We have
Bless you.
plaques, with a line scale, whitish particular patterns,
Okay, and the distribution?
I believe this is
I'd say probably interdigital. We're spreading toes, probably like fourth and fifth toe.
Okay. So, I guess it has more scale on like a vascular process, atrophy.
So atrophy blanche tends to be ankles and infarctive white areas. This to me looks like the white is coming off and underneath revealing red, suggesting it's maceration of epidermis. So like an interdigital tinea, and then what goes with that is what's called dermatophytosis complex. If you look at people who are prone to this, their lateral web spaces are squashed close together. They don't have any air space there for circulation, and so they're chronically macerated there. So they walk around with maceration. Then diphthroids overgrow. The ones with diphthroids tend to be a little stinky. The ones that are purely tinea or maceration tend to be a little less stinky. The problem with the diphthroid overgrowth is some of the products formed are antifungal, so that even though there may be an interdigital tinea underlying, it's very hard to prove it either by culture or by KOH, and yet it's part of the process and has to be addressed as part of the process. And the diphthroids themselves, because they tend to be commensals on the surface, are usually discarded as anaerobic garbage. Right, so you usually aren't going to yield anything with a culture or KOH, and so it's purely a clinical diagnosis. And then management, how would you approach this? Pink and purple. So you're referring to gentian violet and Castellani's. And also permanganate is really good. The problem is the pharmacists don't like to give out permanganate because if ingested, it can kill you, whereas the others don't, and sometimes old patients get confused. So permanganate is highly effective, but very difficult. So mercurochrome, you absolutely can get some mileage out of. The problem is I see so much allergy to merthiolate and mercurochrome. The mercurials, antiseptics, so many of the older generation were sensitized as kids when grandma, every cut or scrape would get merthiolate or mercurochrome on it. And so I see a lot of older patients with recurrent cellulitis where they get the recurrent cellulitis because they're terrified of cellulitis. So every cut or scrape, they're putting their mercurochrome or tincture of merthiolate on, giving themselves a contact, and then giving themselves cellulitis because of the contact. So that vicious cycle you see, it's not that it's not efficacious, it's just that I'm a little gun shy.
I haven't seen it in a long time.
All my old patients seem to have their bottle from the 1940s still on the shelf. and they seem to love it. It may be the same bottle Grandma was using on them. So it's definitely still around, but gentian violet, better for yeast than dermatophyte. The Castellanis, not bad for both and for that whole soup of gram negatives and anaerobes that tend to grow in the area. And usually you can suspect the anaerobes because of the stench. And when you're using the Castellanis, you want to use the full-on pink Castellanis, not the colorless or phenol-free. Other things that can work is mechanical debridement. So you take away all the dead macerated skin and then do things like dilute vinegar. So 0.025% acetic acid, or Dome Burrow, or your Castellanis at that point. But debriding a lot of this dead skin really helps the process along. And then the other thing they have to do is they got to get used to sticking cotton balls or dental rolls or something between their toes, or if they go to the drugstore, they can buy the foam things that women use to put their toes apart when they're painting their nails, and put those between their toes and stick a fan on their foot while they're watching TV for a couple hours and just let it dry out a bit. And this one actually fluoresced with erythrasma as well. So, the difference there would be just that you might add erythromycin or clindamycin for the erythrasma. Okay, how about this one?
So, neoplastic causes alopecia neoplastica, lymphoma, cutis.
So alopecia neoplastica, lymphoma, cutis. Of those, how many of those would tend to preserve follicular orifices?
Well, alopecia neoplastica by definition would not.
So alopecia neoplastica by definition would not, and most lymphomas and things tend to be pretty taut, rounded surfaces. This is more something that's maybe growing around follicles rather than displacing and destroying follicles. So think of things that go around follicles that would give papules as well as a plaque. And think of your lumpy bumpy face differential.
I don't have a lumpy bumpy.
You want to jump in with the lumpy bumpy face differential? So I heard tuberous sclerosis, which is exactly what this is. Other things, Birdhog Dubé, where they're pale, often on the nose. Brooks Spiegler, where they tend to be melolabial fold and redder. So what's the clue for this being tuberous sclerosis? You have a lumpy, bumpy face, and there are angiofibromas, which, like a fibrous papule, is often perifollicular but preserves the follicle, right? The forehead plaque, and why do you get a forehead plaque? It's a manifestation of loss of heterozygosity. So you have lost one allele, and then by sporadic mutation, you lose a second allele everywhere you get a bump. And if you have a postzygotic mutation giving you loss of heterozygosity in a whole Blaschko segment, then you have more monstrous manifestations in that whole segment. And then, is this the normal width of a Blaschko segment on the face, or is it too wide and plaque-like, or too narrow and skinny? Let's say too wide and plaque-like, which is everyone's doing it with motions, but you are correct. The nonverbals were good. which would suggest that this is a lethal gene, B, a tumor suppressor gene that has been knocked out, or C, neither. Tumor suppressor gene. So things like segmental neurofibromatosis and the forehead plaque of tuberous sclerosis are broader than the normal Blaschko segment because you've knocked out a tumor suppressor gene, so the tumor is no longer suppressed, right? And you get excessive growth expanding the Blaschkoid distribution. So forehead plaque of tuberous sclerosis is a manifestation of loss of heterozygosity, but the risk to the child is still 50-50 because it's an autosomal dominant gene. Right? Okay, David?
Well, so there's alopecia, frontal, scalp, and bilateral users sparing the midline.
So cicatricial alopecia and its distribution. Frontal. So this is sort of classic frontal fibrosing alopecia. So it's marching backward. You have the corkscrew, curly, coarse hairs that have been described as resembling genitalization of pubiciform hairs, yes. But that is what suggested the use of drugs like dutasteride, because suggesting something maybe hormonal with this type of lichen planopilaris, and then the violaceous appearance at the base and the silvery spines, which were a little far away to see that.
Do you CellCept for that variant too, or not?
I do. So, but before CellCept, I will start with things like PPAR inhibition, with pioglitazone, which I will definitely try in them, and then I would try dutasteride, which I wouldn't try in other forms of LPP necessarily. And I've never had good success with Plaquenil, but then most of them end up with mycophenolate.
Alright, so you do like it in the end.
Yeah. If they haven't shut down with the other things. Okay, and then this, you might think of a frontal fibrosing, but you'd also think of a female pattern. The one thing is, do you see a spared frontal fringe? Not really. It's more thinned all the way to the front, whereas female pattern tends to preserve that frontal fringe and then thins behind it. So that suggests that this might actually be frontal fibrosing, which I believe is what it was on biopsy. Okay, how about this one? Yeah, I agree. I mean, that looks sort of post-inflammatory, and then there's something in the middle, right? And this was furuncular myiasis, guy who had traveled. So the little thing in the middle is the punctum. It's a botfly larva. Okay. And
is this still like contact from your bleached rubber?
So, contact from bleached rubber syndrome, is that likely to be papular or likely to be a more continuous band? And are you seeing scale here?
No.
Yeah, I'm not even sure whether it's scale or just light reflex that we're seeing. This to me looks more papular, and papular in a segmental distribution, which always gets me thinking something genetic with a postzygotic somatic mutation or loss of heterozygosity. So then you're going to look for manifestations elsewhere on the body to say, is it loss of heterozygosity with more likely a 50-50 type of inheritance, or is it postzygotic somatic mutation, which on the trunk maybe a 1 or 2% bigonadal mosaicism. And it looks like someone has been there with a biopsy. So what things might you think of? You might think to do the biopsy, and that's probably would get you in the right direction. These show GA. Yeah, not classic. Maybe you can talk yourself into some of these arrays being annular. Other thing I would definitely have thought of would be like a Reed syndrome patient, where these would be smooth muscle, where they'd be leiomyomata. Stroking or rubbing them to see if they become taut and painful can sometimes be a helpful sign in that case. Things you see dermatomal distribution of adnexal neoplasms, especially spiradenomas, that can be in this kind of distribution as a postzygotic somatic mutation. Okay, one last one.
She has a lot of lentigines on her chest.
So lots of lentigines on the chest. So, she could just be Irish or...
It's like a classic Charleston patient. People spend too much time in this.
Exactly. It could be just a poikiloderma of Savat. Could be syndromal lentiginosis, although the distribution suggests the former, right?
Mm-hmm.
Now you got forearms.
Could still be a Charlestonian.
Could still be a Charlestonian.
You could also think about.
And this was Golly Golly. So this was from Tim Berger. So you're going to end up being biopsy. It probably would have been from a younger age, and it's going to look like Dowling-Dagos, but with acantholysis. So Golly Golly. Okay, so we have to, for next time, remember where we were. We are slide 85. And you get your little preview of your patient you're going to have to manage next week. Good. How many sets of slides? Oh, we're on set 2 out of 14 regular. Then we get into CPCs and management, and so there's lots. Okay, so slide 85 for next time, and for those who joined us remotely, we will see you next time.